you for those of you that can stay, but I understand we're running a little bit over time. Hopefully you'll find it useful if you are able to bear with me for the next 20 minutes. So the overview of what I'm going to talk about today, well, I don't need to speak too much about irritable bowel syndrome, but what I will do is tell you about the use of prebiotics and probiotics in IBS and whether or not you can add these to a low FODMAP diet. I'll then talk about IBD, so UC and Crohn's disease, and pre and probiotics in these. And also I'm going to cover constipation as well. So I've got lots to go through. So I'll just get started. So first of all, prebiotics. I did my PhD in prebiotics basically, but they are often something that people haven't heard a lot about or don't think a lot about. They're sort of the poor cousin of the probiotics. They're essentially selectively fermented substrates, so they're selectively fermented by the gut microbiome, and that confers a health benefit to the host. So they're not meant to feed all of them, just the probiotic type of bacteria. So typically we think about bifidobacteria when we think about prebiotics. Having an increase in prebiotics also leads to an increase in fecal short-chain fatty acids. So as we heard before, these can be an anti-inflammatory type of metabolite, and specifically butyrate. So an increase in butyrate helps to fortify colonic cells, as well as being an anti-inflammatory type of molecule within the colon. So if we think about prebiotics in IBS, they're not commonly used. If you think about a low FODMAP diet, basically you're removing anything that might be slightly prebiotic when you put patients onto a low FODMAP diet. But there have been previously quite a number of studies where they have investigated whether inulin-type fructans or GOS or other types of prebiotics might be effective at treating symptoms. So last month I was lucky that I had my first PhD paper published in AJCN, which was a systematic review and meta-analysis of prebiotics in IBS and functional bowel disorders. I don't expect you to be able to read that, but just looking at the big black diagonals at the bottom, you can see that actually overall for different symptoms, when we looked at prebiotics, they weren't effective in IBS. However, when I went on to look at subgroup analysis, so looking at inulin-type fructans, which are a card-carrying FODMAP, compared to other types of prebiotics that might be less fermentable, I did find that there were some differences, particularly for the symptom of flatulence. So inulin-type fructans, unsurprisingly, did make flatulence worse in IBS, whereas prebiotics that weren't inulin-type fructans actually made it better. So it depends on the fibre type. I then looked at dose of prebiotics in IBS, and again I found that there was a difference depending on the dose of prebiotics that you gave to patients. So flatulence again was the main symptom that was affected. So a low dose prebiotics seemed to make flatulence better, whereas higher dose had no effect, but you can see that the diagonal is sort of onto the side of favouring placebo. Reassuringly, as we know that patients with IBS have got lower bifidobacteria than healthy controls, we did find that in IBS, prebiotic supplementation increases bifidobacteria. So it does work via the kind of prebiotic mechanism we expect it to. But what about thinking, how does this fit into current dietary treatment for IBS? So thinking about prebiotics, restricting prebiotics as in the low FODMAP diet, we do know that this tends to make symptoms better in IBS. However, as was pointed out, this does significantly lower fecal bifidobacteria, so those friendly type of microbes that we want more of. As I've just said, supplementing with prebiotics can both induce and reduce symptoms, but we know that prebiotics can increase bifidobacteria. So what I did for my PhD was a large randomized control trial of combining the two therapies to see whether or not I could maintain bifidobacteria while reducing symptoms. So I conducted a 3-arm randomized control trial in 69 patients with IBS. I had 3 groups. So I had a control group that had a fake diet. They didn't know that they were on a fake diet, but they did, and a placebo sachet, or they had a low FODMAP diet with a placebo sachet, or a low FODMAP diet supplemented with a non-ITF low-dose prebiotic, so one that I thought was likely to make symptoms better. What I was aiming to do was prove that you could add a prebiotic back into the low FODMAP diet and still get a better symptom response than on the control group. and I was aiming to maintain gut bifidobacteria, comparing the low FODMAP diet, which I expected bifidos to go down on, compared to the group that had the prebiotics. So I expected that the bifidobacteria wouldn't go down in that group. So that was my trial that I ran. So the first thing that I was aiming to see was whether or not I could improve symptoms by combining the two therapies, and as you can see, the low FODMAP and prebiotic group did have an improvement in symptoms. So the dual therapy seemed to be more effective than the control at making symptoms better. So it seemed like, yes, this was a great idea. Thought we'd done really well there. And it wasn't just overall symptoms, it was also individual symptoms. So abdominal pain, loose stool, and overall symptoms were lower in both incidence and severity at the end of the trial in the low FODMAP and prebiotic group. So remember, the second hypothesis was that I would maintain gut bifidobacteria. So you can see the control group at the top there. So the control bifidos didn't really change. Low FODMAP went down a little bit, but the low FODMAP and prebiotic went down even more. So basically, I had to reject my second hypothesis because we had a significant decline in bifidobacteria with this prebiotic. So as well, the short-chain fatty acids, so the beneficial anti-inflammatory type of molecules that I was hoping to get more of with this prebiotic, by 7 days, most of the short-chain fatty acids had reduced in both groups that were following the low FODMAP diet, and at 4 weeks, butyrate, which is the specific one we really want to have more of, was significantly lower than the control. So it didn't really work via the prebiotic type of mechanisms. I'm not going to talk too much more about that. You can ask me after if you want to. So the conclusion of that was that you could add this low-dose BGOS prebiotic to the low FODMAP diet without reducing symptom response, but there was no significant benefit. So there were no differences between the low FODMAP group and the low FODMAP and prebiotic group. So even though it looks like a few more got better, there were no significant differences. So it's not worth putting it in to say, oh, you're going to get even more better if you take this as well. And also, as I said, it didn't maintain bifidobacteria. That takes me on to probiotics, so the other one. So adding in the live bacteria, how does this work in IBS? So there was the BDA guidelines that came out a few years ago in 2016, and there were 35 RCTs that were identified, and they systematically reviewed to see, which probiotics and what symptoms and what did they make better. And one of the interesting findings that they found was that repeat studies using the same probiotic got different results. So it wasn't like a consistent, if you take this one, this is what's going to happen. Less than half of the studies that measured overall symptom response to probiotics reported that they were superior to the placebo. And they also reported that there was no evidence that multi-strain was better than single-strain probiotics. They reported no adverse effects, but the conclusion there was that just taking a probiotic on its own is probably not enough in terms of improving IBS symptoms. But then last year, a new systematic review and meta-analysis came out from Alexander Ford's group, and this one included a greater number of randomized controlled trials. And what they did find was that there was some benefit, particularly with multi-strain or Escherichia coli or Escherichia single-strain probiotics. There was a lower rate of symptom persistence in IBS. So those two results there. So interestingly, I thought that single-strain bifidobacteria and lactobacilli probiotics didn't lower the rate of symptom persistence. Multi-strain probiotics did reduce global symptoms or abdominal pain scores, whereas single-strain didn't. However, probiotics weren't effective at managing bloating, but they were effective at reducing flatulence. So overall, if I had to choose, I would probably rather recommend a multi-strain probiotic, just given that there seems to be more evidence that these are effective at managing symptoms in IBS according to this latest evidence. This has already been touched on, so talking about adding a probiotic to the low FODMAP diet. So this was done, this trial was just finishing when I started my PhD, so Heidi Staudacher, and it was published in 2017. Basically, she took 104 patients with IBS, put them either on a low FODMAP diet or the sham diet, and gave them either VSL or placebo. And for this one, she had similar aims to me, trying to maintain the bifidobacteria on a low FODMAP diet, and she had more success with that than I did. So you can see, compared to low FODMAP diet alone, where the bifidobacteria went down significantly, when the low FODMAP was supplemented with the probiotic, it didn't. So that seems like that's the answer to the low bifidobacteria in the FODMAP diet. I know I'm not meant to be talking about FODMAPs, but I thought that this was possibly an important point. So this is another randomised controlled trial that's been conducted by Dr. Selena Cox, where she took patients with quiescent IBD, so they had been tested to have inactive IBD, but they still had symptoms to make them fit the criteria for having IBS. And she put them either on a low FODMAP diet or a sham diet, and found again the low FODMAP diet did improve their functional symptoms. But interestingly, she found similar microbiota results to what we see in IBS as well. So bifidobacteria were reduced in these patients. So extrapolating from what Heidi's data showed us, I think it would make sense that if you're putting someone with IBD who's got IBS in remission on a low FODMAP diet, why not recommend that they take a bifidobacteria containing probiotic as well? So that helps segues me into my bit on IBD, so the rationale for microbiota augmentation in IBD. So it comes back to these kind of correlations really between an increase in bifidobacteria and an increase in interleukin 10 positive dendritic cells. So they're kind of immune cells within the gut, and interleukin 10 is an anti-inflammatory cytokine. So when you've got more bifidobacteria, you've kind of got a more anti-inflammatory type environment, which is what you want in IBD. So I've cut this short. I am not fully explaining these studies, but just to tell you some of the kind of evidence that we have for prebiotics and inflammatory bowel disease. So if you're thinking about ulcerative colitis, the main study that's cited is the Casellas study. This one, they took patients with active ulcerative colitis, started them all on standard mesalazine therapy, and gave them either 12 grams per day of an inulin-type fructan, oligofructose prebiotic, or placebo. And they did that for 2 weeks. They didn't measure microbiota. They found both groups got better after 2 weeks in terms of their clinical score, so that was probably just the drugs working. But in the group that had the prebiotic and not in the group that had the placebo, there was also a significant reduction in fecal calprotectin, suggesting that there may have been some anti-inflammatory augmentation going on with the prebiotic. A large randomised controlled trial that was also conducted by our group at King's recruited 103 active Crohn's disease patients and let them stay on their normal therapy and gave them either 15 grams of prebiotic or placebo, and they did that one for 4 weeks. They did measure microbiota and kind of immune outcomes. They found that actually in this active disease, the prebiotic didn't work. It didn't augment the bifidobacteria, it didn't increase it. And they actually found that there was a significant worsening of some of the functional type symptoms, or maybe not functional, but bulbarygmy, flatulence, and abdominal pain were all significantly worsened by the prebiotic. In terms of clinical outcomes, there was no evidence that prebiotics were beneficial for these in IBD. So a bit of a sad story for prebiotics, probably not recommended so much, definitely not for Crohn's disease, maybe not for ulcerative colitis. But given what I found in my primary RCT for my PhD, that, you know, even though there was no increase in bifidobacteria or short-chain fatty acids, these IBS patients did get a bit better, I wanted to explore whether or not this BGOS prebiotic could have some anti-inflammatory effects. And so I conducted a small open-label pilot study, just measuring kind of inflammatory and clinical outcomes in mildly active ulcerative colitis. I gave them double the dose than I gave my IBS patients, because I knew from previous studies they tolerate prebiotics quite well, and I did it for a bit longer in the hope that it would give time for anti-inflammatory mechanisms to kick in. So very briefly, what I found was that the fecal calprotectin was not lowered after 6 weeks, and also clinical scores didn't go down after 6 weeks. So a negative study really, but important to let you know. When I looked at individual symptoms, one thing that I did think was quite interesting was that loose stool incidence and severity were significantly reduced by 6 weeks of the BGOS prebiotic, and that goes from 3.2 days, I don't know if you can read that, but from 3.2 days a week to 1.6 days a week they were reporting loose stool. So in terms, if you think back to the patient, they might think that that's quite a good clinical benefit. Also, when I looked at stool form, there were some patients that had harder and softer stool form, and from both ends of the scale, we saw kind of a normalisation of stool form towards the middle of the road, so from 49% to 70%, and that was again significant. But yeah, to conclude, I didn't get the results I expected. The BGOS wasn't anti-inflammatory. It didn't improve clinical scores. I didn't show you the bifidobacteria results, but it also didn't increase bifidobacteria. But it might help in terms of modifying stool form. So what about the other probiotics? So I'm working at the moment with Dr. Miranda Loma, who was on stage earlier, and we are compiling a large systematic review of nutritional interventions in IBD, and one of the things that we've looked at is probiotics and remission induction in ulcerative colitis. And when we combined all of these 9 RCTs, we found that there was a significant increase in remission rates in patients that had standard therapy plus a probiotic compared to standard therapy plus a placebo. So it looks like it might be, if patients want to take a probiotic, then these were the ones that were used in the studies, and the duration of the studies was 7 to 12 weeks. So they should take one of these probiotics and take it for 7 to 12 weeks, but not as a replacement, as an addition to their standard therapy, if they want to. And I know they probably do ask. Cochrane review on VSL for maintaining remission in ulcerative colitis. So they used VSL because it was the one that had actually some randomised controlled trials. And there you can see is that probiotics were the same as mesalazine in terms of maintaining remission in ulcerative colitis. So that kind of makes you think, okay, well, they could just take they could take probiotics if they don't want to take the drugs. But actually, when you look at it, probiotics were also no different than placebo. So probiotics really sort of straddle the fence there. So mesalazine obviously was better than placebo. Probiotics were in the middle of the two. In terms of Crohn's disease, generally, as an overall thing, there's no evidence for either inducing or maintaining remission, except for S. boulardii. There's 2 studies that have shown that an S. boulardii containing probiotic did help to induce, to maintain clinical remission, and also to induce clinical remission. So if I was recommending, if someone with Crohn's disease wanted to know what probiotics to take, I'd say one that had this strain in it. Then on to constipation. There's not many studies of prebiotics in constipation. I found 3, and that was through scouting for some systematic reviews on this. And so 2 studies showed a positive result. So one was 10 grams per day of GOS, and one was 15 grams per day of inulin-type fructan, so the other main type of prebiotics. And in these studies, there was an increased bifidobacteria, passage of stool, and also softer stool form. And these were just conducted in elderly patients who had some form of constipation. But in kind of adult women, a prebiotic intervention didn't improve constipation. So it's kind of a mixed message there, but it seems like perhaps it's the increase in fibre intake, and it doesn't really matter which prebiotic they choose there, as long as they take a decent dose. In terms of probiotics in constipation, and this is my last slide before my summary slide, so I think I'm just about going to be on time. Another trial that's come out of our group at King's by Dr. Irene Demidi, systematic review and meta-analysis of 14 randomised controlled trials of probiotics in constipation, found that probiotics increase whole gut transit time. Also, so when you look at this, the ones down the bottom have only got 1 study, so that's not really a meta-analysis, it's just the results from 1 study. However, up the top there, where there's more studies, you can see that there was a significant benefit in terms of stool frequency for B. lactis containing probiotics, but not for the LKCI Shirota ones. And also for stool consistency, moving from hard to softer stool, we had the same story. So as long as they're a BKCI one, they seem to be helpful. So this is kind of my take-home toolkit, and I'm happy to circulate this slide if you'd find it useful. So I just wanted to kind of summarise in a table. So if they've got IBS IBS with flatulence, then any non-ITF prebiotic should be okay, but I'd go for a low dose as well. If they've got IBS and they're on a low FODMAP diet, then they could take Bimuno, which was the prebiotic I used in my study, but the dose I used was only half of a sachet, so not a full sachet. For ulcerative colitis, if they want to take prebiotics, they all seem to be pretty well tolerated, but they don't seem to be that beneficial really. For Crohn's disease, I'd say avoid prebiotics, and for constipation, take a decent dose of any type of prebiotic. For probiotics, multi-strain seem to be, for IBS, multi-strain seem to be better. IBS on low FODMAP diet, make sure it's got bifidobacteria in it. For ulcerative colitis, if they're in remission, something like VSL or Vivomix, which are basically the same thing. If they've got active ulcerative colitis, then I've just listed those strains that we identified in those randomised controlled trials. If they've got UC with IBS, then take a bifidobacteria containing low, if they're on a low FODMAP. If they've got pouchitis, I didn't have room to fit this in, but take VSL or Vivomix, that's fairly well established. If they've got Crohn's disease, take one with Saccharomyces boulardii, and a bifidobacteria one if they're on the low FODMAP diet. And if they've got constipation, they should take one with B. lactis in it. And that's it. So thank you very much.